We now have Dr. Mohita Sharma. We all know her, a dynamic surgeon who has a large institute. Thank you. Thank you. She was the one who's the founder of the Women Ophthalmological Society, which has grown strong, which is more than 7,000 members today. She's now the joint secretary of the All India Ophthalmological Society. And with Namrata, who's the chairman scientific committee, I think Sir has two dynamic sisters in this audience. So, Mohita, we are very proud of all the work that you have done and you have achieved and you are doing even today.
Thank you, Ragini, and thank you, Lane sir and Ragini, for inviting me here. And thank you, Ajanta Pharma, for organizing this very useful meet for all of us. So, what I'm presenting today is Capsulorhexis and effective lens power towards precision. We all talk so much about presbyopia correcting lenses and about premium lenses, and most of our practices are now moving towards premium lenses. um, we talk about their performance, we compare the different types of lenses, and we talk about their defocus curves, we compare them, and we tell each other that this one is better than that. But we forget to talk about Capsulorhexis as a very small step in our cataract surgery, which is going to decide our effective lens position, and whatever lens we may use and whatever calculations we may have done. But if our Capsulorhexis is not what it should be, our results are going to go haywire and our patients are going to be unhappy. In Capsulorhexis, the size, shape, centration, all three matter, because if this is not proper, there will be IOL tilt, there will be rotation, and there will be decentration. And with these premium lenses like advanced monofocals, trifocals, EDOFs, these are the things which will completely destroy your results. Your monofocals may be forgiving, but your advanced monofocals and all your presbyopia correcting lenses are not forgiving if any of these happens. We all aim for a Rexis, considering that 6 millimeters is an optic. We aim for a Rexis which is 5 to 5.5 millimeters with a classic zero point 0.5 to 1 overlap over the Rexis, so that our lens, our IOL gets locked. And once it is locked, it is in its position, and it attains that effective lens position which we have actually calculated by our various formulae. But if it is not locked, if this like rexus is not this size, then our lens can move. It can move forwards. It can move backwards. It can tilt, and all of these will result in our results being suboptimal. In fact, highly dissatisfied patients. We actually work in very non-ideal conditions where many things are not under our control. The pupil center is not under our control. IOL center is not under our control, and matching these is not under our control. So what is under our control is the capsular size, shape, and center, and at least that we can make with precision. All the formula nowadays use help us in finding the effective lens position, and they are designed in such a manner that all these parameters are taken care of. But what about the capsulorhexis? If it is not proper, all these things will go a waste. So this is our ideal rhexis. Now, what happens when our rhexis is a little too large? If it is a little too large, the IOL will move forwards, resulting in a myopic shift, and this can also result in, and when it is a little too large, it can tilt a little also or decenter a little also, and this tilt or decentration can result in astigmatism. In fact, if you find that your patient is dissatisfied after any of these premium lenses, and if you do a aberrometry, you may find that your patient has a coma, and advanced cases you may find that they have a trefoil also, and this may be the reason for their being dissatisfied. If your rhexis is too small, then there is an increased load of the lenticular epithelial cells on the back of anterior capsule, increased inflammation, capsular contraction, and IOL may get pulled forwards. When it gets pulled forward, then again there is a myopic shift, or it may get pulled a little to the side, which is can result in astigmatism. So we have seen these cases of phimosis, extreme cases of phimosis also. And even if all this does not happen, your IOL may just go, and if it is too small, may go and sit back against the totally against the capsule, resulting in a hyperopic shift. And if it's an asymmetric rhexis, of course, there can be a delayed decentration also. resulting in all these symptoms that we do not want, apart from refractive error in the post-operative period. Now, this is one study. There are several such studies in literature. One only which I'm quoting of 372 eyes, where mean deviation, which compared manual rexes with a laser rexes, and it found that when manual rexes, the post-operative refractive error was 0.55 diopters, compared to with a laser rexes it was 0.21 diopters, which means our laser rexes was working better as far as the post-operative outcomes were concerned. Many a times we tend to think, I can do a very good rexes, why do I need to something like a laser to do it, and why do I need such expensive equipment? But many studies show that actually, when there is a very precise rexes which can happen with lasers, then the results are always better. And the capsular opening is responsible for most of the post-operative refractive errors that happen, as can be seen in the study. Biometry is only responsible for 0.02 error. We are doing very good biometries, and we have good biometers, and we are able to calculate the power very well. So here I would like to tell you that now we all know that it is logical that laser access is more precise and consistent. However, the biggest hindering factor for all of us is the cost. Why has femto not entered into every ophthalmology clinic or every ophthalmology setup? It's only because of the cost. So here I take this opportunity to share with you laser X's that I've been working on with one company for the last 2 years, and this is soon coming in the market, and this is soon enter into every ophthalmology clinic. So this is the equipment setup where you can just put the laser attached to the microscope. And these were the animal studies which were done on this. And these are the kind of rexes that we obtained after the animal studies. And this is the patent for this technology. And I'll come to the video straight away. Since this is indigenously made from an Indian company, it's going to be much, much less, though I cannot reveal any price right now, but it will come within this year, maybe in next 1 or 2 months only, and it is much less compared to any femto laser. So this may be the next big thing in ophthalmology. So this is the laser which gets attached to the microscope, and this is a routine phacoemulsification being performed. In this, one very crucial step is staining, because this is a little higher concentration stain, because the laser uptake depends upon how the capsule is stained. And after that, we inject viscoelastic. Again, this is a little higher concentration than the usual viscoelastic. And this is because this is the concentration through which the laser can penetrate. We have worked on various permutations and combinations, and now the focusing part. And here is how that magical rexis happens. So you can see it is a complete rexis. There are no tags in it. And the beauty of this rexis is we can decide on the size of the rexes. We can decide between 4 to 7 millimeters, whatever size we want. We can take that size, and of course, it is going to be consistent. Every time we want it that way. Every time we want it 5.5. Every time it will be 5.5. So it's very, very precise and consistent. And you can see the strength of the rexes. It's a coagulating laser. Since it's a coagulating laser, it's a continuous coagulating laser, so it has a lot of strength in it. Purposely, I've picked up a hard cataract to show to you, because just to demonstrate that when the hard pieces are also coming out, then also the rexus remains intact. And in fact, we have seen it in under electron microscopy, and we have found that the rexus margins are outturned, whereas the capsular flap margins are interned. Probably this is responsible for the great strength of this rexus. And here is the IOL implantation. We have also checked on the corneal endothelium and compared laser rexes with the manual rexes, and we found the endothelium loss was the same for both the types of cases. And just to demonstrate, whatever size we want, we get that size with this kind of rexes. So these are the electron microscopic pictures. Finally, I end my talk by saying that effective lens position is crucial for best results, and this is dependent on capsulorhexis. The shape and size are controllable factors, and we need advanced equipment to create such a rhexis. But in the absence of advanced tools, we have to be conscious to make a very, very precise rhexis and as precise as we can do manually. Thank you.